Okay, and I will be the host today, and I'll introduce our guest presenter in just a moment. As we get started, many of you are entering the webinar. I'd like to welcome you and let you know that your mics will be muted throughout the webinar, and you will be able to ask any questions you have by using the chat feature. So if you'd take a moment, please, to get familiar with the chat feature. We'll be monitoring your questions through the webinar and get to as many of those as we can during this hour. American School Health Association is a multidisciplinary professional association, and our mission is to transform all schools into places where every student learns and thrives. The American School Health Association envisions healthy students who learn and achieve in safe and healthy environments, nurtured by caring adults, functioning within coordinated school and community support systems. And that's great because the topic today is about those safe and healthy environments. The membership benefits of joining the American School Health Association include the Journal of School Health, which is our peer-reviewed, indexed professional journal that's available in print and online. Continuing education such as this, members receive free continuing education credits, and that includes the Journal of School Health self-studies, live and on-demand webinars, and our annual conference. Members receive discounts on select AAP publications, as well as a discount to the Sex Ed Network and job postings on our Career Center. And also, members receive information and expertise, access to the latest in school health through our annual conference and bi-weekly newsletter. And I'd also like to, here's the memberships. I'd also like to invite you to save the date for our upcoming annual conference. The American School Health Association Conference this year will be in Albuquerque, New Mexico, September 30th through October 2nd. And with that, I'd like to introduce today's presenter. May Erouart is an MPH with the Children's Health Fund. She manages training and partnerships for Healthy and Ready to Learn, a program of the Children's Health Fund that addresses health and social issues that impact student learning. Since joining the Children's Health Fund in 2018, she has trained individuals representing over 100 schools in New York City. Her background is in public health with a focus on health promotion. May came to the school health field through working with select New York City community schools on needs and assets assessment and strategic planning while pursuing her MPH at Columbia University's Mailman School of Public Health. This work sparked her interest in promoting safe and healthy learning environments as a way to impact both academic success and social determinants of health. We're going to switch slides over, and May will step up as soon as we get her slides loaded. So just a moment, please.
All right. Great. So hopefully everybody can see that. I can't see myself anymore, but as you can see, I am in a car. And so I just wanted to address that up at the top because as many people I think are facing different resource issues, our Wi-Fi has been really spotty. And so me and my mom, who is a teacher, have been taking turns taking the car to the local high school to do our video conferencing. So that's why I'm in a car. Today I'm going to be talking to you guys about connecting families to health resources in your community. And I just wanted to also give a brief background on our program, Healthy and Ready to Learn. It was started 6 years ago to address health barriers to learning. And it started with, on the left, you can see our school-based programs, where we had a full-time site manager who helped to coordinate health screenings and health education and parent workshops and professional development, and a full-time mental health clinician who saw a small caseload of students. And both of them worked together to do case management, and they still work together, do case management around chronic absence and helping connect families to resources to really address some of those underlying root causes to the academic barriers that we were seeing. And as a result of this work, which is really amazing work, but hard to scale, we created the Resource and Training Center 3 years ago to help disseminate some of the lessons we were learning, and to be able to make the resources that we are creating more available to people across New York City and now across the whole country too. So as part of that, we have our website, the Online Resource and Training Center. I'll show you guys that at the end. We have our in-person trainings, which I run, and we have a technical assistance program with an additional 3 schools. So the schools that we work with are largely based in the South Bronx, and we also work with a school in West Harlem. And so I think, like everybody else right now, we are struggling, or not struggling, but we're scrambling to adjust to our present circumstances. So we have been creating a virtual learning series that's featured on our website. You can see this is what the page looks like when you get there. But I also wanted to say that this training originally was created to be an in-person workshop that we did at schools to help them create resource binders to help with referral making at the school level. And as we are adjusting to these new times, we're realizing that this information is more useful than ever, and with a little bit of tweaking and some reframing is still completely relevant to what's going on and has been pretty easy to adapt to a virtual framework or a virtual platform. So today, we're going to talk about the historical roots of some of the health and educational disparities, because I think it's important for us to look at these things and continually raise them to the forefront and ask ourselves why some communities are bearing the brunt of what's going on more than others. I'm going to describe some ways and tools to identify resources in your community, and how to start making a short list for resource referrals that you can make with families or other staff partners. And then I'm going to talk about some strategies for collaborating with school staff, and to start having those conversations and making those referrals and making those connections. And I wanted to say, please feel free to ask questions at any time during the presentation. Wendy can interrupt me, and if we need any clarification or we want to go deeper on one thing. I'm used to doing this in person, where I get to feed off the audience, so please feel free to weigh in. So what are health barriers to learning? What do we mean by this term? Our program focuses on these 6 in particular: hearing problems, vision problems, asthma, dental pain, hunger, and behavioral health. Of course, there are many more health barriers to learning, but we focus on these mainly because in the communities that we work in, largely medically under-resourced communities of color in the city, we find that there's really high prevalence of these particular health issues, and these also have a very outsized impact on student learning and their ability to learn in school, right? Of course, if a child can't see the board, it makes it a lot harder to pay attention to what's going on. And we are finding that every time we do vision screenings, at least a third of our students have either undiagnosed vision problems or their prescriptions are out of date, right? And these particular health barriers to learning are important. It's important to recognize that these present more of a barrier in communities that are under-resourced, that are struggling, that are combating many other determinants that make it harder to have what they need. And in affluent communities and largely in white communities, these particular health issues present less of a barrier, right? Because people are getting care they need earlier, they're getting preventative care, they're addressing these things in screenings, they have treatment plans in place. So we see these particular barriers presenting such, being so prevalent in the schools that we work in because of these long-standing systemic issues. So why do we have these issues, right? Why are these health issues patterned the way they are? When I do this presentation in person, I like to get a show of hands to see how many people are familiar with this map. But I think I'll just tell you, I'll just give it away. For anybody who is already familiar or is not familiar, this is a map of New York City from 1939. It's a redlining map. So this, the redlining process or practice was something that was very frequent in the late 1930s and 40s. And it was essentially maps that were created to help or to guide where money would get investment, what loans the federal government would back, right? And they were graded on a scale of A, B, C, or D, and the scales were around quote unquote safety, but a large way that they weighted certain communities over other was the ethnic and racial makeup of the communities, right? So the most desirable quote unquote neighborhoods, the first grade neighborhoods, were the ones that had the least proportion of people of color, and the red neighborhoods were the ones that had the most Black residents, and actually Jewish residents were one of the ways that they outlined these neighborhoods. And what this did was it shaped which communities got investment and which communities didn't, right? So this was just another way of pouring resources into communities that were already doing well, and starving other communities of much needed financial resources. And the impacts of these practices have been felt, they're still being felt today. And I'm going to show you that now. So I want you to pay attention to these particular areas. This is northern Manhattan, the Bronx, central Brooklyn, and a portion of Queens, right? So this map is from 1939. And now I'm going to show you a few maps from the 2018 New York City community profile. And before I move on, I just wanted to remind myself actually, that these maps this is not a New York City specific practice. This happened in every major city in America. This happened across the country. It was a federal program. So if you're not familiar with your area, I highly recommend Googling to see what the redlining maps looked like in the communities that you work in, because it's very illuminating. So again, this is the 2018 community health profile. And as you see, the demographic skew of the city is still very similar, right? We still see our communities of color concentrated in the same areas, more or less. They've been pushed down and out a little bit to the east and to the south. This is the breakdown of non-Hispanic Black residents. And then if you add in the Latino residents, you see the Bronx populating in Upper Manhattan. So just to show that even the housing segregation has persisted since that time of the redlining. This is a map of avoidable hospitalizations among children. You can see the same areas. Avoidable hospitalizations among adults. I'm sure you guys are familiar with that term, but if you're not, avoidable hospitalization means any hospitalization that occurred or that presented that was due to a treatable condition, a condition that should have been caught in preventative or primary care, escalating to the point where it was so severe it needed to be hospitalized. So this is an indicator, a proxy indicator for low access to primary care. As you can see, the same neighborhoods have the highest percentages of poverty, right? The highest concentration of poverty in the city. And education indicators are also patterned in the same way. We have some of the highest rates of elementary school absenteeism in these same communities. And this is the most recent map, which is also from our city's public data database. And this is the total count of COVID-19 cases based on patient zip code. So I'm just going to toggle back and forth. You can see that a lot of the same areas are highlighted. The darkest purple are the areas that have the most number of reported cases. So there's that map. There's this map. Unfortunately, those of us who have been doing this work for a long time are not surprised, right? We're not surprised by these maps, and that's really unfortunate because it's clear that certain communities are being disproportionately burdened by what's going on. And it's really important in looking at these data to remind ourselves that there's a difference between markers and drivers, right? This quote I think really perfectly sums it up, which is that being Black by itself doesn't cause poorer health. It is the systematic discrimination and racism that causes poorer health, right? The reason we see these issues pop up the way they do and pattern the way they do is because there have been longstanding tradition of racist and oppressive practices that have shaped the access to health, shaped the access to resources in our communities. And unfortunately, the communities that often have the fewest resources are often the same communities that have the highest concentration of our most vulnerable residents. as we can see from those maps. And I've been reading a lot about this term in light of COVID-19 in particular, which is this idea of toxic inequality, right? Using the word toxic really to denote that inequality affects the health of all people, both at the high end of the socioeconomic ladder and at the low end. And I think now more than ever, we're seeing that play out because COVID-19 doesn't discriminate, but it does spread a lot more easily and faster in communities that are starved of resources, and then those that jumps over to everyone else. So I can't say this as eloquently as this particular artist puts it, but I wanted to highlight, my coworker sent me some of this artist's work, and I think she really sums it up so well. Her name is Danielle Coke. She operates mainly on social media, but on the left you can see, I think she has a really great depiction of why Black America is suffering more. If you're not aware, Black Americans are getting infected at higher rates, and they are also dying at higher rates from COVID-19 related complications than white residents, white Americans. And this is really because we planted these seeds of systemic racism that led to inequities that caused things like housing discrimination, poor housing quality, high poverty rates, which makes it harder to access healthcare. Many workers don't have paid sick leave. They don't have savings, so they can't, they have hourly jobs, they can't stop working, so they put themselves more at risk. All of these things lead to higher risk. And it's not just COVID-19. If we look at pretty much any other chronic condition, and the same thing happened with H1N1, we see the same patterns play out over and over again. And on the right is another depiction that really shows how privilege protects us from the storms of crisis, right? If you think of the rain as being adversity, people with more privilege obviously get less wet, right? If we have the ability to work from home, if we have stable housing, all of these things protect us. So it's important that when we're doing this work, and especially in the context of finding and connecting families to resources, that we're also never forgetting that the reason that some are suffering more than others are because of these seeds that we planted a long time ago, and it's all of our responsibility to name these things and to be vectors of change and reparation. So many of you are probably familiar with Maslow's hierarchy of needs. The basic idea is that there are certain needs that need to be met before we can advance to more elevated needs, right? Our physiological safety needs need to be met before we can address things like maintaining our relationships or working on our self-confidence. The highest peak is self-actualization, and that's all about, cultivating our creativity and our spontaneity. In terms of school performance, that's, that goal setting, being the A student, striving for better, pushing ourselves, all of that happens at the top of the pyramid. And when we're doing this work and we're thinking about connecting people to resources, we need to figure out where they're at on the pyramid, right? What needs, what level of needs need to be addressed before we can move on? And sometimes this especially happened before all of the COVID-19, we would have a call with the family and say, oh, you have a question? No? Okay. So frequently what would happen is we'll have a call and we'll say, oh, we want to reach out to this family because we want to talk to them about attendance, and we want to improve their attendance. And then when we have the call, we realize, oh my God, this family are so preoccupied right now because grandma is sick and they're having a hard time paying medical bills, and all these other things are going on, and we can't have the conversation about attendance, right? Because there's a safety need or a physiological need that hasn't been met yet, and we're trying to talk to them about esteem or self-actualization. And so I think when we're thinking about tailoring the resources and conducting these conversations, that we're keeping in mind, how can we triage the cases that we're getting? How can we triage the information that we're getting, and really find resources for each rung of the pyramid, or for each level of the pyramid, so that we can make the right recommendations and the right connections. I also think it's really important for us to recognize that COVID-19 is pushing all of us down this pyramid. It really is, and it's important for us to be compassionate with the people that we are working with, but also for ourselves, because we'll talk about this in a minute, but like, what are the outcomes of this work? What are our goals? And it's important that we are also recognizing that we're in this too, and we're feeling it too, and that we also have needs that need to be met, and we need to be attending to those as well. So in terms of reframing our metrics for success, we used to really focus on outcomes first, right? Those are the numbers. And we wanted to have big numbers, right? We wanted to make sure that we were making as many phone calls as we could, that we were, getting really good rates of referral follow-ups, people taking the referrals that we were making, that we were reaching as many parents as possible. But sometimes those outcomes can hide the depth of what we're doing, and we were finding that sometimes some months, or we track these numbers on a monthly basis, some months we would have way fewer actual interactions, maybe fewer phone calls, but they were longer or they were deeper. One year we might have fewer parents on our caseload, but we had a better relationship with those parents, and it lasted 4 years rather than someone falling off the caseload pretty quickly. And that made us think about how we really need to reframe some of our outcome measures and think about how we can prioritize relationship building, prioritize trust building, and especially in the context of working in communities that have been historically, as we just talked about, really disenfranchised and abused in many ways by institutions. We, as representatives of institutions, representatives of healthcare systems, representatives of schools, it was our work to rebuild trust and to rebuild those connections. And that in and of itself is a positive outcome. So it's not an either or, but it's a relationships first and then outcomes way of approaching this work. And keeping in mind that trust is one of the most important components of doing this work. So what else can we do? We've been working with the New York City Community Schools Department of our Department of Education. And so they came up with these buckets as part of a joint training that we've been doing. They have a toolkit, I'll show you a link to that at the end, called the Benefits Access Toolkit, and this is from there. And they categorize the work into 3 phases: the prepare phase, the reach out phase, and the connect phase. This is not necessarily linear. Sometimes we're jumping back and forth between these phases based on, how the work is unfolding, how, what conversations we're having. But essentially, we want to make sure that we have resources on hand, that we've identified the resources that we'll be needing and using most frequently, that we're collaborating with school staff, with our partners, and most importantly with families, and trying to assess what the needs are, making sure they know where they can find the information once we have it, and then connecting, right? Really making good referrals, making warm referrals, and all throughout building trust. So in the prepare phase, this is all about making sure that we've assessed what information and what resources are even needed, right? It's really overwhelming right now. I think we can imagine 800 different things that will be needed. And if we jump in from that point, we will definitely be overwhelmed. And we know, because my team did this week 1, we made a list that was like, I don't even know how many items long. And then over time, we've whittled it down and said, okay, well, here are actually the 3 buckets that the conversations are leading to most frequently. And the best way to get this information is to share knowledge, to talk to your teams, to talk to families, and really identify what needs are coming up over and over again as the most pressing, and then being able to triage based on what those categories are. The next is to scan what's out there. I'm going to show you a few websites that we use frequently that allow you to search by zip code and also by filter. I don't know if anybody in the audience is familiar with Aunt Bertha. That was what we used before. It's a really good aggregator. It's national. And I know a lot of clinics actually use Aunt Bertha and the social work departments to help connect families to resources. I'm going to try to shift my screen to show you. Sorry, technical difficulties. Everything is up at the top of my screen at one time. Okay, here we go. Okay, this is Aunt Bertha has created a new kind of offshoot of their website that's completely focused on COVID response programs. You can get to regular Aunt Bertha just by clicking there, but I think this is a really good place to start. It's called findhelp.org, and it allows you to search by zip code. Um, oh no, the Wi-Fi is breaking. So it allows you to search by zip code, and it has categories like emergency food, financial assistance, food delivery, food pantries, telehealth resources, telemental health. Oh, here we go. And so what you can do, and I recommend that, you know, if you want to multitask, which I usually do, you put in the zip code and you can select language. You can get more specific with your categories. You can add filters. This is really good if you're looking for specific age ranges or specific populations. This is just a really great tool, but as I said, it can be overwhelming because it shows you everything. I definitely recommend, well, I used to recommend putting a physical limit on the radius, but now, of course, everything is being done by phone and virtual. Um, so play around with it. Um, the other resource I want to show you, and I'll describe why in a minute, is the HRSA Find a Health Center website. This allows you to locate FQHCs by zip code. This is really important, and I'll talk about FQHCs in a minute, because it allows you just to get a sense of the different clinics that are available that will accept all patients. I know that in New York City, a lot of the smaller clinics are pivoting to create rapid response testing sites, so that more, especially they're targeting the same populations that we talked about in the maps, right, of Central Brooklyn, the Bronx, Northern Manhattan, and Queens, to make sure that COVID-19 testing is happening in the communities that need it the most right now, that have the least access.
Hi, May. It's Caitlin. We have a quick question in the chat box.
Yeah.
Is Aunt Bertha for all parts of the country, and also is it available internationally?
I don't know if I've never gotten that question before. I don't know if it's available internationally. It's a national website. It should be available all over the country. Um, to my understanding, it's updated at least once a year to try to make sure that the resources that are listed are current, if not more frequently than that, but I am not sure if it's available overseas, or at least over the border.
Thank you.
No problem. So yeah, that was Find Help. This is what it looks like when you just land on the home page. As you can see, it has COVID specific and language right up at the top. And so FQHCs, which I just mentioned on that HRSA map, for those of you who aren't familiar, FQHCs are federally qualified health centers that get special funding from the federal government. They get higher reimbursement rates to provide community health care to medically underserved or vulnerable communities. And part of that requirement is that they act as medical homes, which means that they provide coordinated care, comprehensive care, meaning not just primary care, but also have mental health, oral health, women's health, vision services, all of those things in network, if not in the same facility. And they also specialize in connecting families to insurance. And as part of their funding, are required to treat all patients regardless of ability to pay. So they all will do sliding scale fees for patients who don't have or are ineligible for insurance. And they must see all patients even regardless of immigration status. So I think these are an amazing resource for the communities that we serve. Now more than ever, I think there are so many Americans who are finding themselves without adequate health care. And I definitely recommend trying to locate your closest FQHC and just calling them and reaching out and figuring out what they're doing. Because I know I have a few friends that work at FQHCs. They've been scrambling to get all of their telehealth services up and running so that they can still provide care to families at this time. And so next we have our reach out phase, right? This is how we go about making those connections and compiling them into digestible lists, right? I recommend making your own tailored resource list. If you just rely on those big aggregators, you'll quickly be overwhelmed. There are so many different resources, and it's just, I mean, from personal experience, very overwhelming. In regular times, we have actual physical binders that we keep in our school. And we make sure that we have resources on hand for all of the questions and topics that come up most frequently at our school. So that is primary care and community health centers. I know that specifically when we have new student enrollment, some of our schools have very high percentages of students in temporary housing, so we get pretty frequent enrollments. This is a really great time to have conversations about connecting to local healthcare centers, community health centers at our school. We have information about vision and dental, hearing providers, health insurance resources, food pantries, all that stuff we keep on hand, and we keep it in one place. Now, of course, we've shifted that to, we created an open Google spreadsheet. This allows us to update it in real time and share it really easily, but we lock it so that people have to request if they want to add things or make edits. But this has been really helpful. And as you can see, we've bucketed ours by topic, right? So we have a few food resources, a few financial resources, our mental health resources, all in one place. And we have this publicly available to our school communities. I've seen a few of these floating around, so there might already be something for your community. I definitely recommend some like local nonprofits or health centers might have a list already available. So you should just, ask around, going back to that collaboration piece. Yeah.
This is Caitlin again. There was a question about what percentage of the schools you work with have health centers? And if they do not, who do you work with?
So none of the schools that we work with have school-based health centers. We work with a combination of local clinics and nonprofit partners that come in, do screenings. We've also been working very, very closely with our school nurses. We've been really cultivating a deep partnership with the Department of Health School Nursing Division to help make sure that our health resources in the schools are being tapped. And then when we have health requirements that are beyond what school nurses can provide, we've cultivated relationships with our local FQHCs actually.
Great, thanks. And then a couple other ones. Is the local resource worksheet available online, or can you share that with us?
Yep, absolutely. I will share the PDF with Caitlin after this is over. And so when they put the recording up, it'll have the related resources next to it.
Great, thank you. And one last one. What were the categories your resources are bucketed into in that Google Sheet?
Oh, on the spreadsheet, I believe we have mental health, we have food resources, financial resources, virtual learning resources, and I think we have a telehealth or a health bucket. Those are our 5 main buckets. We've also, I think, added we added one more. We added like a activity idea bonding bucket because we were getting requests from people for non-computer related fun activities to do for stress busting, which was a nice thing to get a request for. So we've been keeping track of those too in that same place.
Awesome, thank you.
No problem. And so when you're making these lists, it's really important that we vet them. Going back to that, always making sure that we're building trust. A good referral goes a long way in building trust, but we can ensure that these referrals or these connections are good quality we used to walk around the neighborhood and physically visit them, and now we call them. On the first week that we were quarantined, our team, especially our school-based team, were on the phone just nonstop trying to, make sure that when we recommended a link for free Wi-Fi that families would actually be able to get through, mapping out where the resources were, what's still open, where our closest we have in New York City, we have these regional enrichment centers that provide schooling and childcare for first line responders. Just making sure that we knew where all the closest resources were, who was giving out food, etc. And either visiting those places ourselves or making sure that we were connecting with partners that we knew that were on site, just so that we had a good understanding of what our families could expect when they connected with those resources themselves. And I think it's important to also call out that, things are kind of a mess right now. And some of the places that we referred people to, or that we usually refer people to, are completely swamped. The user experience, the the visitor experience for those resources has changed. And sometimes, you know, we won't get through, but I think having a conversation, and we'll talk about this in a little bit, having a conversation where we call that out and we set those expectations up front really goes a long way, and just building that relationship and building that connection with people. So here's the connect phase. Making the resource lists available, well, obviously not in various areas of the building, but making sure that various touch points, so whoever families are connecting with, know where they can find that resource. I recommend that you send it out and just ask everybody on your team to have it bookmarked so that anytime they're on a call, or they're emailing somebody, they can just pull it up easily and have all the information at their fingertips. And I really recommend encouraging other school staff to refer students and to have conversations about connections. Right now, it's definitely an uncertain time and it's overwhelming, but any person that has a close relationship is the right person to have that conversation about health resources, to have that conversation about financial resources, because asking for those things often requires a good amount of trust, a good amount of, you know, space to be vulnerable. And sometimes, you know, you're not the right person to have that conversation, but somebody else that you work with is. And so, you know, working together to make sure that resources are getting out to the right people at the right time, in ways that are compassionate and strengths-based for families. And share knowledge, right? If you get information, it's more important now than ever to communicate and to over communicate and make sure that everybody on your team is really comfortable with these resources. And that we just continually remind one another that we're not alone in this. And that, you know, if one person finds something good, that everybody else also, you know, has access to it, because otherwise we all end up with 50 different tabs open on our computers and none of us have the same 50 tabs open and we're duplicating the work. I know that so from experience. And then it's also important that we think about, you know, how we're having these conversations. How we say what we say is just important as, okay, I said that anyway, you know what I mean? How we say it is just important as what we say. And that, you know, we're on calls, we're distracted, we're multitasking, but that if we're having an important conversation with a family who's probably really going through it, that we're using, you know, a warm tone. Body language seems like something, it might not be as relevant in a phone conversation or a video conference, but there has been research to show that if you're smiling, that does affect your tone of voice and your mood, and people can sense it. Also, I really recommend starting the conversation with a positive statement. I think all of us can really use that positive reinforcement right now. And that also goes a long way in creating a space, creating a conversation that is safe, safe for vulnerability, and giving people credit for discussing the issue. And, you know, even if they're really struggling, they're doing their best, right? And we have to work with the assumption that people are doing the best with that they can right now, and be compassionate in that way. And then I saw this recently and I love it. Yeah?
I'm sorry, I can wait till you're done with this.
Oh, it's my last one, pretty much.
Oh, okay. We have a question. How effective is sharing resources digitally? And for folks who do not have digital access, what other strategies have been successful?
It's a great question. Sharing resources digitally, I don't know that we have any measure other than anecdotal from families about what's working and what isn't working. I know that there definitely have been some challenges to sharing just web-based resources. Members of my team have been calling families and walking them through, you know, step-by-step over the phone. I was talking to a partner at the DOE, at the Department of Education, who said that some members of their team have had luck connecting with families on different channels. So, you know, if they aren't on email, they're not responding to email, that they're calling or texting them. They've had some luck with social media, actually getting access or to social media accounts for their families and connecting with them through Instagram or Snapchat or WhatsApp, which is a little unorthodox, but I think in these times, any inroad is, you know, is worth jumping on. I've also heard about printing paper documents and having them available at sites that people are going to, but that's, probably not very desirable in this time. Is that
Great, thank you.
No problem.
And I will jump in too and say that Sue Baldwin added that in Buffalo, New York, they're sharing resources via their 28 community school food delivery site.
Great idea. Great idea. Yeah, I have a friend who's a school social worker, who was posting pictures of at their lunch pickup. They had information set up on the tables around the pickup with information that people could read and process, and then talk about with the staff who are coordinating. So that's another way to do it. Um, so just I'm gonna start wrapping up, but I think it's really important now more than ever to also highlight the role of everybody here, right? Of all of the staff who are doing this work. And, you know, if your compassion doesn't include yourself, it's incomplete, right? We have to be compassionate with ourselves. I know that personally, it's been really frustrating to want to make connections for families and then realize that, you know, they were getting iPads, but the iPads aren't working, or, you know, the clinic phones are down, or, you know, I had one of my coworkers who was on the phone with Comcast on hold for about, I don't know, I think 3-4 hours, not being able to get through, and she wanted to ask about getting Wi-Fi to families. And that will happen. That will happen, and it will be frustrating. But we have to just, you know, keep doing the work and putting one foot in front of the other, and be kind to ourselves, and remind ourselves that we are also going through this, that the stressors of this, the trauma of this moment, are real, and that being together and reaching out, and creating these connections, and doing this work in strengths-based and positive ways forges connection, and that connection is a resilience factor, right? That builds resilience, that helps us manage all of this. And so as much as this presentation is really about making sure that we can identify health resources, it's also about making sure that we're having these conversations with families and building these conversations, because even if you don't get through, and you're on hold for an hour, for a family, being able to talk to that family and say, look, I'm sorry I wasn't able to get you this resource. I really tried. At least lets that family know that you're there for them, that you care what happens, that you're invested in their success. And that is important. And that is something that should not be discounted too. So I want to end on that note. Again, this is what our website looks like. I can do a demo if anybody is interested. Two other resources that I think are really great, especially if you're based in the New York area, are the Office of Community Schools website that has that benefits access toolkit that I was telling you about. They have some survey tools that you can use to assess what needs are present. They also have some planning templates, similar to the one that I showed, and that will be made available on the website. We've been working really closely with our partners at New York State Technical Assistance. I'm going to get the acronym wrong, but NYS Teaches. They are the McKinney-Vento liaison and technical assistance agency for New York State. And they have a lot of really great resources around support systems and resources for students and families struggling with homelessness or housing insecurity. And I know that they've really been a lifeline for us in responding to the needs of many of our families. So I definitely recommend looking for those.
May, we have a question from the group about your target age group.
Our target age group, sorry, I'm going to stop. We work with elementary schools. We work primarily with elementary schools, although I have to say in this moment, we've definitely relaxed who we're working with, because many of our families have students who are all ages, who are, you know, they've got some kids in middle school, some in elementary school, and some in high school. So we've been working with everybody because we have a family first approach. But when we are in school, programming does happen in elementary schools.
And then there was a question about, have you seen good impact with virtual mental health resources?
Yeah. Yes, we've seen good impact with the partners. Our counseling partners have still been doing their casework. And I know that's been really important for our families, and has been going well. I think that unfortunately mental health, there's almost always a shortage of providers and care. And I know that different providers have had varying success with their telemedicine platforms, and some of them have, you know, had a harder time transitioning. But I would say overall, and from what I've been hearing, it's been positive. Yeah.
Great. So I guess we'll open it up for any other questions people may have. You can feel free to type those into the chat box.
And while people are doing that, I wanted to show you one more thing. I'm pivoting screens again. Just wanted to show you our website because we've been doing, as I said, this virtual learning series, and we have all of the weeks up with, we've got webinars, but mostly we've got these workbooks that are a really great tool that have guiding questions and activities that are either great for your own planning purposes or reflection, but some of them have really good activities and resources to share with families. So I recommend checking those out. Our website is just healthyandreadytolearn.org. So you can find that here. All right, are there any other questions?
Hi, May. This is Jeannie. I was wondering if you had any insights into, as we return back to school, which we will someday, what are the primary concerns that folks are having about that? Do you have a sense of that right now, or are people just really in the phase that they're in and not really thinking about returning to school, and what concerns them about that?
I would say that I've heard a lot of ambiguous anxiety around the transition back to school, but I haven't those concerns haven't coalesced into discrete topics yet. The biggest things I'm hearing are worries about, one of the biggest ones, especially for our team, is trauma support. So many of our families have already been dealing with an immense burden of trauma, and there are not enough mental health and supportive services to go around. And I know that when we get back from this, our families will be even more, will have faced even more traumatic experiences, but our school staff will also have experienced so many traumatic experiences that they will be even, everybody's cup will be empty, essentially, is what we're worried about. And so we're really trying to think through now how we can set staff support in place so that when we get back, we have those support structures ready to go to support our frontline staff, our teachers, our educators, our ancillary school staff, and make sure that we can really have a wraparound support structure in place at that time. I know that we're also, especially our educators, are really concerned about learning loss and slide. Although I've also heard some people say that, that maybe this time will benefit some people because they'll have more time to practice some of their social emotional skills. They'll be able to, they'll have been working on empathy and creating that awareness. I think it goes either way. But unfortunately, when we think about the disparities that exist in our system, the people who are already facing the brunt of those challenges, those barriers, will have that gap will only have maximized at the end of this. So that's a big challenge that I'm anticipating going back into this is, having to catch up even more than we were already doing before all of this happened. Is that?
Thank you. Mary, you just noted that you turned on your camera. Do you want to pose your question?
We have another question for May. Because many people who are funded by grants are required to provide outcome measures, the question is, what kinds of outcome measures do you have that you might be able to share?
Ooh, I wish I had our data team. We are grant funded as well, and we still have to have the same outcome measures. So we still track all of those things, but we also, I know have been integrating more and more qualitative data collection so that we have that information available when we are able to make a case for it and integrate it into some of our reporting. Of course, we couldn't just do that data collection. We have to also have the process measures in place as well. But I know that we track what's in the phone calls, what kinds of conversations have been had. One thing that's helped us over time is looking at what families have been on our caseload for a long time and the improvement over time of those families. And then using that with some of the anecdotal and qualitative data that we have to kind of put it together into the storytelling, right? And then highlighting those lessons learned as well as just our hard data. So for example, we have one family that, for the first 2 or more years that we were working with them, their chronic absence rates were really high and they weren't moving very much. And then over 4 years of working with the same family, we started to see an enormous gain. And we could map that shift in attendance rates with the actual case notes that we had from working with that family to create this richer picture of what it was, what support it was that was leading to those improvements, right? It wasn't just the number of visits, the number of case conferences that we had with that family, but it was the content of those conversations, the depth of that relationship that really led to those improvements. So sorry, I can't give you a more concrete answer, but.
And Mary had a question. I'm going to unmute her microphone. Mary, you have the floor now.
Hi, how are you?
Hi.
Thank you for this very interesting information. I'm a school health supervisor. I oversee the nurses in the district. We have about 20 nurses in our district, and I was very glad to hear that you're actually utilizing the school nurses. When you say we, what are your titles? Are you social workers? Are you community health workers? What are you guys, what's your profession or your title or?
Yeah, absolutely. So we're kind of a motley crew. Half of our team have backgrounds in public health. So me and one of my coworkers we're MPHs with a background in public health in program development. We have 2 former teachers on our team. We have 1 mental health counselor in training. We contract with counseling in schools who have, we work with 1 clinical art therapist and 1 LMSW. They inform a lot of our work, but they have a number of different mental health clinicians on their side. And then we have one of our awesome team members was actually a parent at one of our schools, and she was the preschool family worker and was recommended to our team by one of our former site managers who was a nurse. She was a former nurse, and she moved on to a different organization and recommended this all-star parent who has now joined our team and works with families as a site.
So
Our site managers coordinate the health screenings. They do family workshops and professional development, and they do attendance case management. And then they work with our mental health coordinators who do the actual clinical mental health care.
Do you guys all work under American School Health? Like, do you work for a district, or do you work for an organization, or who is your team work for?
So Children's Health Fund is a nonprofit.
Okay, I think you did say that at the beginning. I'm sorry, I didn't make sense.
Yes.
So for anybody who's listening, I would highly recommend that you reach out to the school nurses. They really know their families, and they can provide information to you that you might not otherwise be privy to or even know that they know. We've been working really hard in Middletown to better integrate school nursing and, you know, the behavioral health and the social emotional learning and, you know, all of the things with special ed and stuff. So I'm very happy to hear that you guys have been doing that. They're a great resource, and we're better together, as everybody's saying right now.
Yeah, absolutely. Our school nurses have been such rock stars in this work, and we owe so much to them. They informed a lot of the content that we have, a lot of our health content. Actually, we have information about medication administration forms that we, you know, distribute to schools and to families, and they've helped get so much information out there, and partnering with them has been really rich. And what we've been working towards now also is making sure that our partners that we're connected with are also connected with one another. So we've been working with our community school directors and school nurses to make sure that they're also communicating. So thank you so much for saying that. They really are a treasure trove of information. And there are a lot of people in schools that have connections, that have information about families that you wouldn't expect until you start having those conversations and making sure that everyone is at the table and everyone is engaged in these conversations, right? Like, you know, you maybe, I don't know if somebody was telling me about speech pathologists who was still doing video conferencing with a student, and, you know, like they're getting information that maybe the teachers,
Oh, yeah.
It's really, everybody has something to contribute.
Mm-hmm.
May, we have two questions, and we have 4 minutes left, and we have a little bit of closing information for people. So I'm going to give you the two questions at once. One is about funding successes for your team efforts, and then the other is about creating a virtual platform in case it's needed for the fall, and how you foresee returning to school looking like as far as proximity.
Oof. Hey, that's a big question. Well, I'll answer the funding one first. I'm assuming you mean like in this present moment or in general? I'm not sure. In general.
It sounds like it's in general.
Okay, so we've actually been really, really fortunate to have our resource center be funded by the New York City Council, who have really shown that they have faith in us, and that they want to support this work of coalition building between different school partners and supporting school health efforts in more holistic ways. So they fund all of our training, all of our resource creation, our website, all of that work. And then the school staff and our mental health staff are funded through a combination of grants and private corporate donors. And grants. So luckily we have an amazing team who can help us pull all of that information together. But definitely having a strong, I say a data team, we have two people, one who works with our program most of the time. But yeah, having that information ready to go has made it so much easier to kind of pull together funding requests and applications. In terms of creating a structure for the fall, I wish I had an answer to that. I honestly, I don't know what this is going to look like in the fall. I think one silver lining is that I think telecommuting, telehealth, all of those things have been kind of simmering for a long time in the background, in the back burner. I used to work for New York City Health and Hospitals before I was working in this program, and I know that we had been really trying to get more telemedicine programs up and running. And now, because of this, I've seen initiatives that were, tabled for 3-4 years that are now, getting rolled out. So I think that there will be lots of incentive to get those infrastructures up and running, and it's going to be a learning curve. We're all going to have to learn together, but I think that by the fall, fingers crossed, we'll have a moderately functioning infrastructure in place.
Well, thank you, May. We are running out of time, and hopefully everyone has really enjoyed the learning that has taken place and the ability of May and her team to really help families and young people, students during this really challenging time. And in doing that, she's helped all of us during this challenging time also to do a better job with our young people. So just in closing, I want to let people know that we have 2 more webinars coming up, May 14, the Healthy Schools Toolkit, and on May 21, we've got the Health Education Specialist Practice Analysis 2. And so please register for those. Those of you who registered and attended today, thank you so much. You are eligible for getting 1 continuing education hour. You will get an email following this presentation telling you how to access the slides and the resources that May has provided to go with her presentation today. And in order to get your CEs, you do need to complete the evaluation that will be sent to you via email. And if we can help you in any way or you have any follow-up questions, here's our contact information. And thank you very much, May. Thank you for everyone for tuning in. And I hope that you stay well, stay safe, and we'll see you at the next webinar. Bye-bye.
Thank you so much for having me. Bye, guys.
Thank you, May. And Wendy, thank you as well.